Really, it gives me a great pleasure to introduce Dr. Ahmed Kasem, who will give us, who will present his case as a case of stent fracture.
So adherence to time is part of the marker.
Bismillah ar-Rahman ar-Rahim. Thank you, GIS committee. It's always my pleasure to share in this prestigious meeting my presentation today about stent fracture, the unrecognized cause of stent failure. Our patient, 53 years old, Indian male patient with history of left circumflex BCI and stenting in India 3 years back. He diabetic, hypertensive, dyslipidemic, and cigarette smoker. He presented with severe typical chest pain, nausea, vomiting, but he presented to our center later, after 20 hours. Troponin was 19, echo hypokinesia is inferior and lateral wall, ejection fraction 45, and ECG showed only T-wave inversion in the inferior leads. We take the patient to the CAST lab, showed a small non-dominant right coronary artery, and this is the left coronary artery showing normal LAD, but there is total occlusion of the old stent, mid to distal left circumflex. So the question, is it very late stent thrombosis, this patient having a stent more than 3 years back? And remember, with non-STEMI and total occlusion, it is not real non-STEMI. It is what we call STEMI equivalent. All of us know from the classic teaching that non-STEMI associated with partial occlusion, while STEMI in more than 90% of patients associated with total occlusion. But there is some not uncommon percentage of causes causing a typical presentation of the non-STEMI with total occlusion, like our patient having non-segment elevation and total occlusion with troponin 19. And this actually published in very large studies, more than 2,700 patients, showing that the left circumflex is the independent predictors of presentation with non-STEMI with total occlusion of the infarct-related artery due to poor sensitivities of the ECG. And in this study, they found that more than 25% of patients with non-STEMI have total occlusion of the artery, and of course, this presentation having higher impact of mortality and poor outcomes, and this also matched with another meta-analysis and systemic review with the same data finding like our patient. So I decided to go direct for recanalization of this total occlusion of the mid-left circumflex, is the old stent actually, with fielder FC wire with reverse CTO balloon from the beginning, not the workhorse wire. Then after crossing with reverse CTO balloon inflated, and then change it to larger balloon, 2 by 15, and then I replace the fielder FC wire with a regular BMW wire in this patient. But when I using longer balloon, I find the resistance at the middle part of the old stent, and I cannot advance the balloon, which is bigger balloon, high profile, NC to 5 by 30, so I decide to use a very short balloon with 2, 5, and 15, and then dilating this resistance in the middle segment of the old stent. But when I take the stent, I facing the same problem. I facing difficulty. I cannot cross the middle part of the old stent. So I try many times. I find APU is not supportive, so I replace APU to AL1, and also not supportive. I find significant resistance to advance the stent, and eventually when I pull out the stent, it is damaged. So this is actually what we call stent cross failure. And one of the most important predictors and unrecognized and estimated easily the fracture of the stent. So it is the time, according to the European guidelines, in this situation for any stent thrombosis and stent stenosis to use the OCT imaging. While I inject the OCT, first injection, it is non-opacifying the lumen, and I don't find any clear image actually by OCT, so I decide to use Guidezella for more selective injection to left circumflex. And this after injection of the left circumflex I found this is actually the proximal part to the stent. There is atherosclerosis with scattered areas of calcification in this vessel, actually. And this is the proximal half of the old stent. There is in-stent restenosis. There is white thrombus inside this stent restenosis after we dilate with balloon. And of course, we know from the literature that the predictors of in-stent restenosis, multifactorials, biological, mechanical, and technical, but the forgotten cause is a stent fracture. And this actually is a surprise. There is fracture of the stent in the distal part of the stent as the area of significant resistance and obstruction, and we facing the difficulty with crossing of the stent and balloon. So this is actually what we call the multiple breaks with deformation only, without transection or without gap or without total separation. It is a class 3 fracture stent, actually. And of course, the 3D reformats and rendering technique of the OCT showing clearly this deformation of the stent and misalignment or malalignment and deformation of the stent in this area of the stent. And we noticed from reviewing the data and literature that the response of the artery to the fractured stent is much more maximum at the area of the fractured stent with more extensive new intima hyperplasia in this patient. So I decided to use NEC balloon, very short, 3, and aggressively dilate this area, and then using short stent and deploy the stent after that. And this is actually the final results after we facing this difficulty in the not easily recognized. So the role of OCT in recognizing the stent fracture is crucial. And of course, it can easily determine the pathogenesis of total occlusion pattern of an stent restenosis, intima hyperplasia, chronic stent thrombosis, mixed between intima hyperplasia. And from literature, we know that the new intima hyperplasia, it is proximally tapered and patent island insides and presence of fracture as one of the most important predictors of this stent fracture, and also stent thrombosis. Angiographic features is the blunt proximal cap and the pattern specific for this thrombosis, spider web-like, cheese-like, and also the long list of risk factors for this stent thrombosis chronic, and mixed in between the new atherosclerosis and inflammation with hyperlipid contents, rupture of the plaque, and stent thrombosis. This is the 3 major pathogenesis of total pattern of stent occlusion, either acute or chronic pattern. So my final take-home message: total occlusion of culprit artery in non-STEMI is not uncommon and should be dealt as a STEMI equivalent. Stent fracture is under-recognized mechanism of stent thrombosis and in-stent restenosis. Stent post can help in stent fracture diagnosis, but OCT imaging, it is the gold standard and have more efficient tool to diagnose the details of underlying pathogenesis and pathophysiology. Acquisition methodology is actually needed to detect stent fracture, especially we are moving towards thinner struts nowadays with more radiolucent. Thank you.
Thank you, Dr. Ahmed Kasem, for a very nice presentation. I will take just a small comment from Dr. Ala, if you have any comment about the late stent fracture.
Yes, hi.
Role of imaging in.
Just small comments about the case. Thank you very much for this case. You're right, the ECG, the presenting ECG, there was no Q waves, and the troponin was only slightly elevated, so it's with you. And the presentation was typical, so I would go definitely as your diagnosis as it's equivalent to STEMI. The fracture stent, yeah, it's uncommon, and the only way to diagnose it is by using imagery, and especially the OCT, because it will be very clear, or clearer than the IVUS, to see the fracture stent. And you have done a good job by replacing your guide catheter by, instead of having XP, I think you changed it by an AL to have more support, to have access to the calcified fractured stent in the distal or the mid-distal circumflex. I think that's all. Did you ask the patient about the medication? Just what's the status of the medication? Because it's more or less a thrombus on a fractured stent that has been there for a long time.
Yes, this is the typical presentation of very late stent thrombosis.
Yeah.
Patient having marked and significant hyperplasia and then hyperplasia inducing thrombosis after that.
Dr. Ahmed Al-Gundi.
Ahmed, thank you. I just have one comment, essentially, for younger colleagues in the room. A common theme in those complication sessions is battling with stent delivery. Get a guide extension, use it more liberally, be more familiar with it, inchworm it across the region. Then I think a big percentage of the complications in terms of stent loss, in terms of difficult delivery, losing the system, would essentially be aborted. So more liberal use of guide extension.
Thank you. Fadal, Doctor.
I just have a quick, how would you know that actually this fracture in the stent was not created by your crossing the wire, crossing the stent again and pre-dilating it rather than it is like a de novo or something that was there before? I mean, you know, when we pass through the stents, if it's not very well opposed, your wire can go through like under the stent struts. You can pass a smaller, you used a very small balloon like 0.8 or 0.75 as I remember, and you were able to dilate. So my question, how would you really know whether this is because of your ballooning fracture or it's something that happened by itself? Thank you.
Thank you for this excellent question. Yeah, actually, what you are talking about is that inducing by balloon the fracture can occur in the setting of deployment of the stent. But in patient having a stent long time, 3 years back, with intima hyperplasia clearly defined by the OCT, intima hyperplasia protect the stent from fracture. That's why we should, when we're treating stent stenosis and later on thrombosis, we can go for very high pressure inflation by NC balloon for this situation, and it is protected from fracture.
Just a quick note, I mean, that's to a certain degree not correct. You could still go behind the strut, particularly with hydrophilic wires. So you just have to be careful. And to be honest, when they first presented, my thought were exactly the same. Have you gone behind the struts and then inflated that to cause that little kind of deformation of the stent? But stent fracture is something that has to be considered, particularly when we have long stent on a hinge point, and particularly on the cardiac contraction. Down the road, they might fracture. And these are more likely to happen with the smaller connecting, with like the 2 or 3 connector stent.
But is this patient having thrombosis in the lumen? We don't facing any difficulty in crossing with the wire or the balloon at all.
Dr. Ahmed Kasem, thank you very much for your case and kind presentation. Thank you.
Thank you very much.